So welcome back, Sharjeel and Michelle. In our previous conversation, we talked about how pathologists can help patients understand what molecular pathology is and its value in precision diagnostics. But of course, molecular pathology involves sampling and interrogating patients' DNA, which is in some ways the most personal information a patient can divulge. And that can raise a lot of questions about ethics. So in this episode, let's explore some of those questions of ethics, equity, and social responsibility in molecular medicine. So, Sharjeel, let's start with the pathologist's perspective. As molecular testing becomes more integrated into routine diagnostics, what ethical responsibilities do pathologists have in ensuring appropriate test selection and interpretation?
So pathologists have a fundamental ethical responsibility to ensure that the molecular testing is clinically appropriate, evidence-based, and aligned with the patient management. Test selection must be guided by clinical context, validated utility, and potential therapeutic impact to avoid unnecessary or non-informative investigations. As we talk about interpretation, so interpretation requires careful classification of findings, distinguishing pathogenic variants from variants of significance. Also, while avoiding overinterpretation. So reports must be in accurate form and reflects evidence and clearly acknowledge limitations. Equally important is effective communication. So molecular results should be presented in a clinical, clear, meaningful manner, like facilitating understanding among clinicians and increasingly patients. Active participation in multidisciplinary team plays an important role. So it's like this discussion ensures the pathologist contribute not only as a data generator, but as an integral clinical decision maker.
Sure, and Sharjeel, sometimes molecular pathology can reveal incidental findings or genetic risks beyond the original diagnostic question. So how should laboratories approach the ethical challenges of reporting and managing those types of findings?
So in my point of view, laboratories should address incidental findings through predefined, transparent policies rather than case-by-case decisions. Reporting frameworks such as those recommending disclosures of actionable pathogenic variants, like that should be clearly communicated prior to testing. Pre-test counseling plays an important role. So like pre-test counseling and informed consent are essential, like ensuring that patients understand the possibility of secondary findings and can choose whether to receive them or not. So it's up to the patients. Collaborations with genetic counselors is also a critical role in this process. So like if you have any genetical disorders, you have to also consult with a genetic counselor. Additionally, laboratories must consider responsibilities related to variants reclassification over time. And in my point of view, should also develop policies for managing, updating interpretations, ethical practices. Also requires balancing of clinical benefits, like against psychological, social, and financial implications of disclosures. Yeah.
Yeah, really good advice there. Thank you, Sharjeel. Now, quite a provocative question for both of you. Are there any circumstances where genetic testing would not be ethical or beneficial? Michelle, do you want to go first?
Thank you for that question. Well, genetic testing can be extremely valuable, but it needs to be used thoughtfully and in the right clinical context. Before communicating any genetic tests, clinicians should be asking two fundamental questions. What will it do? What will they do with the information? And will patients' insurance cover not just the test itself, but the follow-up care that a positive result may require. If a test result will not change current treatment, will not guide future decisions, and cannot be acted upon medically, then the benefit of testing needs to be carefully weighed against the cost, financial and emotional. I'd like to share a story. My husband's experience with genetic testing for his severe non-diabetic neuropathy illustrates this directly. Bill's neurologist ordered an extensive molecular workup, including the Invitae Comprehensive Neuropathies Panel and the Mayo Clinic Peripheral Neuropathy Gene Panel, 186 gene analysis. The Mayo panel identified a variant of uncertain significance, something that Sharjeel just mentioned, in the SLC25A46 gene, and it was associated with hereditary motor and sensory neuropathy. But it also pointed out this was an uncertain significance. And that means exactly that the evidence was sufficient to determine whether the variant was benign or pathogenic. It was insufficient, pardon me. No actionable finding, no treatment path. His neuropathologist then recommended whole genome exome sequencing with mitochondrial exome sequencing as a first step. That was pursued and no pathogenic variants were identified. Then whole exome sequencing was the logical next step, but Medicare would not cover it. The cost was prohibitive for a couple such as ourselves on a fixed income. What troubled me most was the timing. Bill went through an extensive genetic counseling interview, as Sharjeel pointed out, before anyone raised the question of coverage. Only when pre-authorization was sought did the costs become clear. By that point, he had already invested time, hope, and emotional energy in the process. His neurologist was candid. There are currently no treatments for neuropathy, but whole exome sequencing will contribute Bill's data to a research database that might benefit future patients. So Bill weighed that against his age, being on a fixed income, and the absence of any actionable benefit for him personally. And he declined. That's a reasonable decision. But patients should be able to make it before they are deep into the process, not after. Cost transparency, coverage confirmation, and a clear conversation about actionability belong at the very beginning of the genetic testing discussion, not at the end. There are also emerging ethical questions as AI enters this space. Research has examined whether AI models can predict genetic biomarkers directly from routine pathology slides, for example. Some appeared highly accurate overall, but were relying on correlated features such as tumor grade, rather than detecting the mutation itself. If an AI model cannot demonstrate information beyond what a pathologist can already determine from tumor grade, it's not advancing the science, it's automating a shortcut. There is also justice involved. We now have AI tools that can interpret markers like PD-L1 more accurately, meaning some patients previously denied therapy should have qualified. Who goes back and reanalyzes those cases? When an algorithm improves, justice asks us to revisit prior decisions, not just optimize future ones.
Thank you, Michelle, for sharing Bill's story. That really great example of some of the issues involved. Now, Sharjeel, what's your perspective on the same question?
So like my perspective about this is genetic testing may not be like ethically justified when it lacks clinical utility or does not influence patient management, surveillance, or family risk assessment. Testing without actionable outcome I think it should be carefully evaluated against its potential psychological and financial burden. It is also ethically problematic to conduct testing without adequate pre-test counseling or support infrastructure, particularly for complex genomic analysis. So, as we talk about whole genome and whole exome sequencing, they are quite expensive tests. And as we compared it to like normal pathological tests, so testing in minors for adult onset, not like non-actionable conditions, raises concern regarding future autonomy and is generally discouraged. Additionally, my point of view is that non-clinically supervised or commercially driven testing without proper validations and follow-up framework may lead to misinterpretation and harm. In such context, like ethical practice requires this like restraint, ensuring that testing is guided by clinical benefit, informed consent, and like there should be an appropriate support system. That's all.
Yeah, okay, thanks for that pragmatic view there. Now, Michelle, I'd like to find out from a patient perspective, what ethical considerations do you think should guide how molecular test results are communicated, especially those with uncertain or long-term implications?
I think this is such an important question. Thank you, Helen. You know, from a patient perspective, the most important ethical principle is true understanding, not just informed consent. And there's a difference between signing a form and genuinely knowing what you're walking into. Another story. My husband, Bill, is a 2-time melanoma survivor. His daughter wanted to understand her own genetic risk, not only for melanoma, but also for glioblastoma, the brain cancer that had taken her mother's life. She underwent a full cancer genomics panel and learned that she carried a variant in the MITF gene, which predisposes her to melanoma and potentially renal cancer. She did not carry a genetic predisposition to her mother's brain cancer. But once she had her results, she needed to know where the MITF variant came from. Since her mother had already passed away, she could not ask her. So she asked my husband, Bill, to be tested, and he was confirmed as the carrier. Now, my own experience followed a different path. When I was diagnosed with breast cancer in 2006, only genetic testing available were for the BRCA1 and BRCA2 genetic mutations. I didn't carry either mutation, which meant my breast cancer was likely environmental, not hereditary. The results was clarifying for my whole family. It told my mother and my sisters something important about their own risk profile. Years later, already understanding what a positive result would mean for them, I made the informed decision to undergo the full cancer genomics panel. Because Bill and I have no biological children together, my results had no implications for his side of the family. My concern was entirely for my sisters and my mother. The knowledge I had going in made all the difference. These two stories together illustrate something clinicians must communicate clearly before any genetic test takes place. Results do not stay with the individual. They ripple outward through families in ways that are often unexpected and sometimes across generations. Bill's daughter's situation is a vivid example of that reach. She now knows she carries the MITF variant, predisposing her to melanoma and renal cancer, the same risk her father has lived with. That knowledge has opened the door to early monitoring and intervention for her, but she also has 3 boys, our grandchildren, who may carry the same variant. The insurance implications for them are real and long-lasting that could follow these boys for decades. All traceable to this genetic result first discovered in their grandfather. A single result found in one generation can cast a shadow or shine a light across the next 2. Patients need to understand up front that these results can affect eligibility for life insurance, long-term care policies, and future healthcare coverage, and that these implications extend not just to the person being tested, but for their children, grandchildren, siblings, and parents. This is not a reason to avoid testing, however. It's a reason to ensure that true informed understanding, not just a signed consent form, is in place before testing. But informed understanding only matters if patients can access testing in the first place. And that is where the equity conversation becomes impossible to separate from the ethical one. Research published in CAP Today documented significant underrepresentation of Black patients and other patients of color in adult genetics clinics at major academic medical centers, including the University of Pennsylvania Health System and Mass General Brigham. These are not community health centers with limited resources. These are flagship institutions. If disparities exist there, they exist everywhere. Patients in rural communities, those without insurance, and those in lower income households face compounding barriers. They may not have a physician who thinks to recommend genetic testing. They may not live near a facility that offers it. And increasingly, as healthcare costs rise, many patients are facing an impossible calculus, whether to maintain their insurance coverage or pay for groceries and housing. When that is the reality, precision medicine is not a choice, it's a luxury. This is the equity dimension of the ethics question. It is not enough to communicate test results responsibly to patients sitting in front of us. We have to ask why so many patients, disproportionately Black, brown, rural, uninsured, and lower income, are never making it to the conversation at all. The ethical responsibility does not begin at the point of testing. It begins at the point of access. When patients are fully prepared and equitably supported, molecular diagnostics can be extraordinarily empowering. But that empowerment depends entirely on who gets through the door. And right now, the door is not open equally.
Yeah, thanks, Michelle. That raises such a lot of important questions there. So I'd like to dive into the equity questions and themes that you raised there. So I'll put that to Sharjeel. Sharjeel, access to advanced molecular diagnostics can vary widely between regions and healthcare systems. So what steps could be taken to reduce those disparities in access?
Like for reducing disparities requires both systemic and institutional strategies. It is like laboratories can implement reflex testing protocols to standardize access to essential molecular diagnostics, but minimizing reliance on individual clinicians' awareness. I think that like partnership with reference laboratories and adaptation of digital pathology and telepathology can somehow extend I think yeah, that somehow extend specialized service to undeserved or underserved regions. Pathologists also plays an advocacy role in improving reimbursement policies and supporting coverages, and like for also for clinically indicated tests. Equally important is clinicians' educations regarding test availability and access pathway, ensuring that existing resources are effectively utilized.
Yeah, thank you. And I'd also like to pick up on the theme of underrepresentation in molecular data sets that Michelle raised there. So some data sets have been found to underrepresent women in some cases or certain ethnic populations in other cases. How can the field address those types of bias?
Addressing population bias requires deliberate inclusion of underrepresented groups in genomic research and biobanking initiatives. This involves community engagement, equitable requirement strategies, and international collaborations. Laboratories should contribute to shared database to enhance variant interpretation across diverse population, thereby reducing disparities in uncertain results. For AI-driven diagnostics, diversity in training and validation dataset is essential. Tools must be rigorously evaluated across heterogeneous population before clinical deployment to ensure equitable accuracy and reliability.
Yeah, thank you for that. And Michelle, let's go back to you. From your experience, what are the biggest barriers preventing patients from accessing molecular diagnostics? You've mentioned that insurance is quite a big one. What are some of the other ones, and how might those disparities affect outcomes?
I think this is such an important question, Helen. Thank you. The biggest barrier is access. And you mentioned financial, geographic, and really awareness. And all three compound each other. Because of our family's experience with genetic testing, I'm acutely aware of how much depends on simply having the resources and the knowledge to pursue it. Well, what about the patient who doesn't have those advantages? They don't get the follow-up testing. They don't get the monitoring. They don't get the early intervention. They get the late diagnosis. The Quick DNA program in Wales, I read, offers one of the most compelling real-world demonstrations of what becomes possible when those barriers are removed. Through the NHS, where universal coverage means no patient faces a bill, I read an article in the Pathologist, Helen, that liquid biopsy ctDNA testing was enabled directly into lung cancer and breast cancer diagnostic pathways. And the results were striking. Median time to genomic results dropped from 26 days to 14 days. And time from suspicion to treatment allocation dropped from 98 days to 45. For patients whose tissue biopsy had failed or was insufficient, liquid biopsy stepped in and delivered results that tissue testing could not, meaning some patients received targeted therapy only because of that pathway existed. This is not a marginal improvement. For those patients, it was the difference between treatment and no treatment. What it also pointed out was that the quick DNA model is so instructive, not just with speed, it's the integration that they found. Testing was not an add-on or an optional referral. It was built into the pathway from the start, tied directly to actionable treatment decisions with no financial barrier standing between a patient and the results that could guide their care. Every patient in the NHS system had the same access, regardless of income, geography, or insurance status. That stands in sharp contrast to what patients in the United States often experience. Access to molecular diagnostics here can depend on which state you live in, which health system your physician is affiliated with, whether your insurer covers the test, and whether you can afford the out-of-pocket costs if they do. The technology exists. The clinical value has been demonstrated. The barrier is, as Sharjeel pointed out, structural, and it's solvable if there's a will to solve it. If access to biomarkers determines access to treatment, then access to testing is access to survival. Precision medicine risks becoming precision privilege if we don't address this structurally.
Yeah, that's that example from Wales is a real good news story, isn't it? It just shows that the blueprints are out there for how to make the system work more equitably. So I was also wondering, Michelle, what role should patient advocacy groups play in ensuring equitable access to these sorts of testing?
Helen, I think this is such an important question because I believe patient advocacy groups are the bridge between scientific innovation and the patients it's supposed to serve. And right now, that bridge is critically important because many patients still don't know what molecular diagnostics or precision medicine means for their actual care. Advocacy organizations can do three things that no one else in this ecosystem does. Number one, they translate complex science into language patients can understand and use. Number two, they push for policies that expand access and ensure insurance coverage for clinically appropriate diagnostics. And three, they bring lived experience into the rooms where decisions are made, research priorities, trial design, and coverage policy. Through my work with the American Society for Clinical Pathology, the American Cancer Society, I'm also involved locally with the Michigan Cancer Consortium and the Digital Pathology Association and the My Pathology Report website. I've seen how much it changes when a patient's voice is generally included, not consulted at the end, but embedded from the very beginning. You know, one of my primary goals and mission in advocacy is democratizing patients' access to their own pathology and laboratory results, including molecular pathology. Patients have a right to understand what their test results mean, not just receive them. The ASCP and the Digital Pathology Association are important partners in that work, helping to advance the infrastructure and policies that make patient-facing pathology communication possible. One specific area where this matters enormously right now is biomarker literacy. As Dr. Jason Wasserman, who is the founder of the My Pathology website, noted in a recent article in The Pathologist, he said the biggest unmet need in pathology communication today is helping patients understand why biomarker tests are performed, what the results mean, and how they affect treatment. Patient-friendly path reports are a direct response to that gap. And I also work to reach patients directly through multimedia channels, my own YouTube channel, Empowering Patient Engagement, and on LinkedIn. You know, not every patient is reading medical journals or sitting in conference room halls. Many are awake in the middle of the night, searching online for answers in the quiet moments after a life-changing diagnosis. This is the audience advocacy must reach, and digital communication is how we meet them there.
All those initiatives sound fantastic, Michelle. It's really great to hear about those. Thank you. Now, I wanted also to talk about the safety of patient data. So, Sharjeel, what responsibilities do labs have in protecting patient data while still advancing research and innovation?
Laboratories have critical responsibilities to safeguarding genomic data, which is, I think, inherently identifiable and sensitive. Compliance with regulatory frameworks must be complemented by robust institutional policies emphasizing data minimization, purpose limitations, and transparency. Secure data governance, structure, and control access mechanism are essential to maintain patient trust. Emerging approaches such as um, federated learning offer opportunities to advance research while minimizing data sharing risk. Ultimately, ethical data stewardship requires balancing innovation with confidentiality, ensuring that scientific progress does not compromise patient privacy.
Yes, and because patient data is being used for research, I wanted to ask you both how you think patient communities can be meaningfully involved in shaping those research priorities related to molecular diagnostics. Sharjeel, would you want to go first?
Yeah, like meaningful patient involvement requires integration at earliest stage of research design rather than like post hoc consultation. This is my point of view. Patient provide valuable insight into clinical relevant outcomes, communication gaps, and assess barriers. Incorporating patients' perspective also into study design, diagnostic development, and policy framework enhances both scientific validity and I also think real world applicability. Institutional patient engagement through like advisory boards, collaborative research models, and funding requirements ensures that molecular diagnostic involve in a patient-centered and ethical grounded manner.
Yeah, thank you. And Michelle, how would you like to see patient communities involved in shaping research priorities?
If I may, I would like to comment on the data protection question too, before I go into your question. And just mention that from the patient side, the data protection is not just a regulatory checkbox. It's a matter of trust. And without patient trust, the data pipeline that the entire precision medicine ecosystem depends on will erode. Patients whose genomic data fuels AI training and biomarker discovery deserves transparency. How is the data being used? Who has access to it? And what safeguards are in place? I ran across an interesting bit of information here in the United States. The Centers for Medicare and Medicaid Services actually launched an anti-fraud initiative called CRUSH, which is examining laboratory services, including genetic and molecular diagnostics. And from a patient perspective, preventing fraud and unnecessary testing is important, but cost control efforts must not unintentionally limit access to these tests that guide treatment or identify inherited cancer risks. To your question regarding patient involvement, well, I think this is so important. Patient involvement is essential for responsible and accurate innovation. Patients often ask practical questions that researchers and clinicians may not always consider. Will this test actually change my treatment? Will insurance cover it? How might this information affect my family? And patient communities, as Sharjeel pointed out, can contribute by serving on advisory boards, participating in research discussions, helping design clinical trials, and reviewing patient education materials. As AI pathology tools emerge, patient involvement becomes even more critical. We need patients in the room where decisions are made about which data sets to train on, which populations to validate in, and how results are communicated. As Sharjeel pointed out, including patients in research and policy discussions help ensure that advances in molecular pathology are developed with both scientific integrity and patient trust at the center.
So, Michelle, then looking ahead, let's think about what the vision is. What would socially responsible molecular pathology look like from the perspective of patients and families in the future?
Thanks, Helen. Great question. From the patient perspective, socially responsible molecular pathology comes down, in my opinion, to three things. First, equitable access. Patients should be able to access appropriate molecular testing regardless of where they live, what insurance they have, who their physician is, or their ethnicity. Number two, clear communication. Patients need understandable explanations of what molecular test results mean and how they affect treatment decision. Biomarker literacy is the biggest unmet need in pathology communication right now, as Dr. Wasserman pointed out, and patient-friendly reporting is a direct and achievable solution. This matters more urgently than many people realize. Biomarkers and immune checkpoint pathways are now driving precision medicine. Determining who qualifies for targeted therapies and immunotherapies can be transformative. But these concepts are not fully understood by all clinicians, let alone patients. When ordering physicians cannot fully explain, for instance, a PDL1 score or a tumor mutation burden result, what it means for treatment options, that knowledge gap travels downstream. For patients, these biomarkers remain completely invisible. Invisible terms on a report, invisible factors in a treatment plan, invisible opportunities for therapies they may never know they could have. A patient cannot advocate for treatment they have never heard of, explained to them in language they can understand. And third, responsible innovation. New discoveries must be rigorously validated before guiding care. Research published in an article mentioned in Cell Reports Medicine identified, for example, uncharacterized orphan RNA molecules that appear highly specific to certain cancers, some detectable in blood as potential tumor-specific barcodes through liquid biopsies. That's extraordinary science, but extraordinary science still has to earn its place in clinical practice through validation, not just excitement. Innovation without equity widens survival gaps. Ethics in molecular medicine is not about slowing innovation. It's about ensuring that innovation reaches everyone it claims to serve. I just want to say thank you, Helen and Sharjeel, for coming together to host this important interview. And thank you so much for this opportunity to share my thoughts as a patient and patient advocate.
Thank you, Michelle. Thank you for sharing your insights. And any closing comments, Sharjeel?
I think Michelle highlighted all the points that every patient experience. So she herself also suffered from the whole scenario and also pointed out all the difficulties that she or every patient face regularly. As this discussion is all about ethical point of molecular pathology. So my part is that as we are moving towards the AI and digitalization, we all know that data can be easily manipulated and can be easily misused. The genetic data, like the DNA, is the core of every organism. So it should be protected from any harm. And molecular testing should be feasible for everyone. As Michelle also said, that it is non-affordable for most of the patients. And if we compare from one continent to another continent, some continents are doing molecular tests like liquid biopsies for free, or they are including it in the screening process to mandate poor patients. So these policies and frameworks should be reconstructed to enhance the patient and doctors community.
Great. Well, that's a great message to end on. Thank you. So yes, once again, thank you very much, Sharjeel and Michelle.